Welcome to Real World NP's Clinical Pearls, where we take gems from full-length episodes and break them into quick, digestible insights. I'm Liz Rohr, family nurse practitioner, and my pronouns are they, she. Real World NP is a continuing education company for nurse practitioners in primary care, especially new nurse practitioners navigating the role transition from RN to NP. Whether you're on your commute between patients or prepping for an exam, these bite-sized takeaways can help you build confidence in your practice. Let's dive in.
So I have a confession to make, and actually I'm sure that you have this as well. There are certain topics that I'm just not as excited about. I really like the intricate diagnostic puzzles, and atopic dermatitis is not necessarily one of them. Hold that thought though, because dermatology is hard, but eczema may or may not be easier to diagnose than some other ones, but the real magic comes in the treatment, because I think that as a community, as a profession, we don't necessarily serve our eczema patients to the highest level that we could. And I did some CEUs recently, and I really wanted to share all these beautiful pearls that I got in my own care, especially, I don't know if you've ever been in this situation, but I frequently get little kiddos, this applies to adults too, by the way, but little kiddos that are coming in, the parents are just exhausted and near tears, the kids are crying the whole visit, they're covered in eczema. Like, you have a huge role to help those kinds of people, and this happens all the time in my family practice clinic. So if you're new here, I'm Liz Rohr from Real World NP, and you're watching NP Practice Made Simple, the weekly videos to help save you time, frustration, and help you learn faster so you can take the best care of your patients. So in this video, I'm going to be breaking it down with some really helpful paradigms and insights and clinical pearls to really practically apply to your care of these patients, knowing when to refer them to dermatology, the care that they should be doing at home, and answering questions like what creams to use and what allergies should be testing for, like all that stuff. So stick around, I'm going to share my screen with you.
So eczema has a huge impact on the quality of life. I just want to start with this because I think it really helps you if you haven't experienced those, that screaming baby or the adult that comes in asking you again for the injectable steroids that their dermatologist gives them when they have eczema flares. Like, I just want to paint this picture for you of how distressing this is as a diagnosis, as a condition rather. So most patients have daily itching, and it sounds like a minor symptom, right? But it can drive people absolutely crazy. It also impairs their sleep, and I think that's especially important for kiddos, for babies that are up crying all night and the parents are exhausted, or the kids that aren't performing well in school because they're not sleeping well. Also, school-age kids can have things like lack of self-esteem, bullying, impaired school performance due to lack of sleep or related to the other issues that are coming up for them. It's exhausting, and a lot of parents feel really inadequate because they feel like they can't get a handle on it, they can't get control over it, and it's a lot of maintenance, and you're going to see that in a second. A lot of patients come in and they'll say, "We've tried everything," and I've definitely experienced that myself. So it's something you want to think about. A lot of times it's like primary care clinicians are throwing spaghetti against the wall, and I feel like that's kind of what I was doing as well, even though I kind of understood how to treat eczema. But hold on, and we'll go through it. The main point with that is that we need to try things in the right combination, and that's like my main takeaway of what I've learned. And I think that gives patients a lot of hope, and hopefully it will give you a lot of hope too, putting this all together. And before I go any further, there's a cheat sheet down below this video if you want to download that to follow along with this presentation, and also to keep at your desk for quick reference. So eczema, it's really important to think about it as a lifelong roller coaster. I've always said to my patients, this is a chronic illness. It's not going to go away. But I think when you paint the picture of like it is a roller coaster for everybody, there's guaranteed ups and downs, and people try their best to maintain it, but in some ways it's out of our hands, that when things have flares. And so I think if you set the expectation of like it's going to be like this, that can be a little bit easier as well. And then I think a helpful reframe that I've kind of learned for myself is that it's similar to asthma in that there's flared rescue treatment as well as the maintenance care. And the maintenance care is so key. And I think that it's also the most exhausting part. So you'll see that in a second. Also, the main thing about when it comes to eczema rather, is about breaking that itch scratch cycle when it comes to flares, which I'll talk about in a second. So just stick with me. And then treatment for eczema works best when it's used consistently and all at the same time. But it can, again, be hard and it can be exhausting. So the goals of care. So number one is all about maintaining and repairing the skin barrier. And so The main thing is moisturizing with emollients, but we'll talk about the other skincare, and that is like the underlying ultimate key because when you protect that skin barrier, then it tends to there's just like a lot of research that supports that it can have so many positive effects and reduces the risks of further flares and other complications, and on a very, very small level too. Number two is again controlling the itch because when you have patients that are itching, it's going to make it worse and it's just going to get into this nasty cycle. Helping with sleep, that's got to be a really important component to your treatment. Treating and preventing infection, which I'll talk about, just kind of being mindful of when it's infection and when it's not. And then treating flares and inflammation on a kind of a preventative basis. So stick with me and we'll talk about all of these things. So maintenance care. So this is going to look like a lot, but it's not that bad. It really comes down to skincare and avoiding triggers. So, skincare is daily use of emollient. So, hold that thought. We'll talk about that. But basically, it just means creams that are thick enough that you can't use a pump. Because if you're using a pump, those are more like lotions and they're not typically enough to be considered an emollient. It's important that they're hypoallergenic, fragrance, and dye free. And daily bathing, there's been some confusion and controversy whether or not patients should kind of go every other day with their bathing versus daily bathing. And I think the general recommendation in now is that, and it depends, you have to work with your family, right? So if they're insistent of like, you know what, this is what works for me, like that's fine. Like there's a couple of moving parts here, right? So, but yeah, it's generally recommended that they do daily bathing. 10 minutes of lukewarm water. But the most important thing is that you're patting them dry and quickly applying emollient like right afterwards. Bleach baths are another component of skincare maintenance, and we'll talk about that in just one second. Wet wraps, which another like terrifying like thought or phrase, but hold on for a second and we'll talk about that. Hopefully I can empower you to recommend this to your families and make a big impact in their lives. And again, avoiding allergens and triggers. And so the main kind of triggers that we can be controlling of is things like low humidity, sweat, friction, and saliva. That's a little bit harder with the babies because they drool and drool, but just knowing that that's an irritant. And then potential topical allergens. And so I think myself personally, I get a little overwhelmed with this sometimes because the dermatologist that I was learning from kind of like spewed off this like really long chemical name that she was familiar with that was within a certain number of lotions and creams and all this stuff. And I don't know. I don't think that that's the expectation that we know all those things in primary care. I definitely covet that level of knowledge, but I think it's just important to think about like what are they noticing that seems to get worse, or are there certain soaps or dyes or things like that. So that's maintenance care. That's kind of a lot, but basically it comes down to daily bathing, emollients, and then some other extra add-ons like those bleach baths and wet wraps, which I'll talk about in a second. And then flare treatment is typically when you're going to see them in primary care, but you need to encourage the maintenance treatment. So it's the same skincare, but you want to put out the fire. And you want to add things like topical steroids, which I have another slide on that. So just hold that thought. You want to stop the itch and scratch cycle. So the steroids are going to help with that, but you're also going to consider adding an antihistamine. And so the dosing for that, I feel a little hesitant with this myself because I don't like giving antihistamines to little kids. But hydroxyzine, like if they're up all night itching and scratching, like that's going to help them break that cycle, right? And so the dosing that was recommended was hydroxyzine, a half a milligram per kilogram during the day, and then 1 milligram per kilogram dosing at night as needed. And again, wet wraps, which I'll talk about in a second. And then in terms of asking the kiddos not to scratch, like that doesn't work. So you have to think about all these other things, and cool and cold packs can definitely help with itching as well as distraction. So that's the main flare treatment. And I think the suggestion that was really helpful that the dermatologist was talking about that I learned from was saying that she does like a flare treatment visit to put out the fire. And then she has them come back in about 2 to 3 weeks to assess how they're doing and to talk further about that kind of maintenance treatment. And making sure that that's kind of all working for them. So I want to talk about emollients for a second. People have a lot of questions about that. So again, it's something that's really thick, hypoallergenic, fragrance and dye free. White petroleum, basically no one has any allergies to. And so that's also known as Vaseline is one of the brand names. I'm trying not to be partial to any brands here. Just an FYI, people really love Aquaphor, and it's a really awesome type of treatment. But it has white petroleum and it also has lanolin in it. And so if somebody is using that and they're having reactions or it's not working or the eczema is getting worse, some people can have a reaction to lanolin. Eucerins and CeraVe and Vanicream, these can all be good options too, but you want to look at ingredients because there's different lines for different types. Eucerin, I feel like, tends to be the more bland one. CeraVe just has so many different types of lines within that brand. And so it's important to kind of think about that. I didn't get any clear suggestions because it was a CEU. And so it wasn't really recommended to do any brand names. And so I was kind of reading between the lines there. Vanicream I've been familiar with. Again, this is really not cheap stuff. So something to think about with your patients, but white petroleum is pretty cheap. And then things to avoid, calendula is a really important, popular ingredient right now, but this can be really allergenic for some people. So something to consider avoiding. Also, it can come in things that have a fragrance in them. Olive oil apparently can increase staph and so is not recommended. Coconut oil, again, is another kind of like trendy thing, but maybe just as the preference of your patient. But that's okay to use coconut oil, but you want to use the quote beauty kind and not necessarily like the cooking kind. Apparently, there are differences. If patients want to be using an oil like olive oil, the recommendation that I got from the dermatologist was sunflower extract oil, but I cannot imagine how expensive that must be, especially if you're using large bottles of it all over your child. So something to think about there. So bleach bath. So someone told me about this. I was familiar with it, but I just felt like I didn't have good guidance on it. And so I didn't feel like I could recommend it to patients. But basically what this is a bath 1 to 2 times per week. There's some variable evidence. There's evidence that it's helpful. There's evidence that it's not necessarily more effective than regular bathing. Nothing has come back harmful as far as I understand, but it's actually recommended by the IDSA, the Infectious Disease Society of America, for recurrent MRSA infections. I couldn't find anything that recommended it specifically for eczema, but the thought is that it's anti-inflammatory and it can kill the germs, which is like one of the pillars of eczema treatment, right? And so if you're going to fill a tub, and again, they're different tub sizes, right? But approximately it's a half tub full of water with a quarter cup of bleach. Or if it's a baby bath, it's just 1 teaspoon, a very tiny amount. And the way that the dermatologist referred to it as, which I loved, was a swimming pool bath, which I totally will use in my clinical practice. And I feel conflicted about this, but I think because it's odd to me to use bleach, but I think that seeing the number of patients that I've seen come in with really severe eczema, just really suffering, I think I am going to add this to my kind of repertoire. Wet wraps is another thing, which I just felt like, really, does that actually work? But apparently it does. And it doesn't have to be anything fancy, but basically what it involves is just the cheapest version is to wrap to dress your child or dress the patient in damp cotton pajamas that have been like put in water, like wrung out, are just damp now, and then they just go to bed wearing that, right? Which sounds super strange, but apparently is really effective. And then another suggestion, this is actually a mom's group hack, is that cotton pajamas, depending on the season, right? But you could cover them with a pair of fleece pajamas so it didn't get like the bed all wet, or you could cover it with like a sweatshirt or something like that. But that's the moral of the story with wet wraps. There are a ton of like fancy types of things that people can buy, like I don't know. I don't even know the brand names, but yeah, I don't think you have to get fancy about it. I think you can just kind of wrap it up. So topical steroids, I feel like is such a huge, the main question, right? And so topical steroids, you can use these up to about 15 days per month. There are different formulations. There's creams, oils, ointments, and oils and ointments tend to be the preference. But again, I always defer back to cost because just the patient population that I work with, but also like who wants to spend like a ton of money on this, right? I don't know. It seems like it will add up. So oils, apparently there is like a fluocinamide oil. Anyway, I haven't ordered that myself yet, but I'm going to. Ointments, and then also you can wrap those up. And so with eczema, you can get those like lichenified plaques where they're really thickened from all the repeated excoriation, and it can be hard to penetrate that. And so a suggestion is that you can put the topical steroid on and then just wrap their arm or wherever wherever it is with like some sort of plastic wrap for like 15 minutes or something like that, just to help it penetrate a little bit better. The thought behind the 15 days is that if it's more than that, they might need a different maintenance plan than what you kind of have in front of you. So they might need a dermatology referral if you're getting a little bit fancy here, or they're getting a little bit more complicated and more on the moderate to severe side versus a mild eczema. And then another thing to think about is like, do we have the right diagnosis here? Do they have a bacterial infection on top of it? And so signs of that would be things like increased redness, drainage. You could consider mupirocin, which is a topical antibiotic treatment for that. And then another thing that the dermatologist sees a lot is that there's post-inflammatory hyper or hypopigmentation, that people can tend to think that this is still eczema. But the kind of rule of thumb there is that it really should feel like something. Like it should feel, if it feels like sandpaper, then you can go ahead and apply it. But if it feels just like normal skin that's a different color, then don't use the steroids anymore. And that's really important. I think with different, there's many different types of skin tones and different presentations that you'll see eczema in, and it really comes down to itch and then the feel as well. There's also a table of steroid potencies, and so instead of giving you specific names of the different steroids to use, I'll give you the classes that are recommended. And so class 1 is the most potent, and which is also in the cheat sheet. Um, and So hands and feet can use like the most potent topical steroid. Class 4 tends to be for like the rest of the body. And I have the note here 80 grams, because depending on the tubes that you're used to sending to the pharmacy, 15 grams is not enough to use on somebody's body. So that was the recommendation of the dermatologist, to use at least 80 grams, a large enough tube so that they have enough supply. And then class 6, which is close to the bottom, 7 is the least potent. Those are for the flexural areas and for the face. And you can use a smaller tube, gram amount for the tube for that, so about 30 grams. So food allergies. So this is another big question of like, should I test them for food allergies? Like, do they have a food allergy? Is that what's causing it? So basically no, but you want to consider food allergy in kids under 5 with moderate to severe eczema if one or more applies. So they have persistent symptoms despite optimized maintenance and flare treatment. And the reason I say no is because most of the time they're not optimized in their maintenance and flare treatment. And when you send them to dermatology, they get them to a point where it's under control. Um, so reliable history of food reaction. So they need at least one of those. Um, or yeah, so actually, I think those are the only 2. I thought there were 3, but there's only 2 there. But yeah, if they've visibly had a food reaction, if they have other things like consistent with a milk allergy or other kind of allergy where they have like blood in their stool or something like that, they can be evaluated for milk, eggs, peanut, wheat, and soy allergies. However, definitely send them to derm first, because derm is going to make sure that they're optimized in their eczema treatment. Because if they undergo all that testing, that's just a lot of extra burden for the families to test for that, and then to try to evaluate them and all that kind of stuff, especially like breastfeeding moms that are deciding whether or not to eliminate foods from their diet or change formulas or things like that. So definitely send them to dermatology first. So that's it for this presentation. So thanks so much for hanging out. Definitely let me know if you have any questions, and I'll see you soon.
Enjoyed this clinical pearl? There's even more valuable insight in the full episode. Click the link in the description to hear the complete discussion, packed with practical tips to strengthen your skills and confidence as a nurse practitioner. Don't miss it. And if you found this helpful, be sure to like, subscribe, and share with your fellow NPs so we can keep learning together.